What do we tell the practicing clinician now with treating a patient with renal cell carcinoma from a radiographic standpoint? How do you determine when it's time to switch? Do you have some basic guidelines? I know it's not going to be perfect, but if it's different from RESIST, what are the principles that drive it?
I guess I'll start, but I guess, you know, and I know this is maybe impossible in a busy community practice, you really need to look at your own scans because scan reports are very misleading. A lot of times they're compared not to the last scan, but to 2 or 3 scans ago. So we have patients in Cleveland who go to Florida for the winter, and so they're kind of back and forth getting scans in different places, and so the radiologist just pulls the recent one, but it's not the relevant one because they were on a different drug. I just had that happen, and the report said progression, the patient was going to be switched, and I went back and looked at the films, and the patient was responding wonderfully. So we would have tossed aside a drug that was working, you know, inappropriately. So I think you need to the limits possible, look at the scans, and if you do, then I think you get that sense over time of what is the tumor burden really doing here? Where did the patient come from, and is the pace of increase steep, and we do need to switch versus that real slow, subtle climb out of their nadir, which is, I think, what most patients experience.
And I think the other thing, and your points are so well taken, radiologists are viewing images within the lens of the change in the dynamics of an image. And the one thing, not the one thing, but one of the things that we bring and our people listening to this conference do is they bring the interface between understanding the disease and a radiologic interpretation. And radiologic interpretations are often just that. They're interpretations that don't necessarily apply. We'll have conversations later about immune therapies where tumors grow before they shrink. Is that progression? Obviously not. If we see millimeter changes in a bidimensional lesion on a lung lesion and it's reported as progression by the radiologist, is that clinically important? In my practice, not. And I would encourage, whether it's looking at the scans or talking to your radiologist, to integrate the biology of the cancer that's being treated with the radiographic report so that you're not hastening the switch from drug A to drug B prematurely. And if you question that, what will happen, I think, is what happens in our institution, is the radiologists slowly over time start to change the words that they use in the context of the reports. So whereas before they used to say 1 millimeter larger, 2 millimeters larger, progression of disease, they now say something like tumor A is 2 millimeters difference must be interpreted in the context of the cancer. And so we have to take responsibility for helping them to understand what it is. Now, I mean, they look at lots of different kinds of cancers, but they all appear as you know, abnormalities on a chest CT. Well, a kidney cancer chest CT on a TKI is not the same as possibly a lung cancer chest CT on chemotherapy, and we have to adjust accordingly.
Absolutely, absolutely. I think it's a good point. And you know, I think, remember too, we're in research institutions where we're used to getting some measurements back on these things, so it's a little bit easier to put that into context. But if you're just getting just a text that says progression with no measurements whatsoever, to Brian's point, you absolutely have to look at that, because it very well could be a millimeter or two, which I think we'd all agree is very, very unlikely to have any clinical significance.
And the other thing, and we talked about this just at a meeting just a day ago, is with increased transparency of record reporting given to patients, whereas the patients now have access to the radiographic readouts almost in real time, it's important that we recognize that their interpretation may be somewhat disparate from our interpretation, and it really requires us, I mean, I think Tom's right on. It's the art of delivering care to a patient population, not just the interpretation of the report in the absence of that context.